Okay. Okay, assalamu alaikum everyone. Today is a very high yield lecture. This is my first PAL session, by the way. Feel free to ask at any given moment. Stop me and ask your question. I have checkpoints after every main topic where I'll stop and take questions, and I also have practice questions. And inshallah, they will be helpful, yani. Okay, so before we start, actually, no, let's just get into it. Okay, so we'll be talking about the Valsalva maneuver and shock and heart failure. Okay, so Valsalva maneuver will try to explain the reflexes change in heart rate, cardiac output, systolic and diastolic pressure. And for shock, we'll describe the different types of shock and what they mean and how they affect the human body. And we'll describe left versus right heart failure, diastolic versus systolic heart failure as well. Okay, I'm gonna close the chat. So if anyone wants anything, or if someone's saying something on the chat, can someone please tell me? Because it's kind of obstructing my screen.
Yeah, I take care of that.
Okay, thank you. Okay, so the Valsalva maneuver. As you can see from this picture, the Valsalva maneuver, to be simple, is just holding your breath and pushing. Okay, so it's kind of you do it when you, for example, you're defecating or going to the washroom, heavyweight lifting like deadlifting, and childbirth. But usually deadlifters, you see them when they're lifting weights, they go so that they don't do the Valsalva a lot, because usually they work out a lot, right? And that would cause any chronic use of the Valsalva, which wouldn't be good. Yeah. So it's characterized by changes in aortic pressure and heart rate. It happens when you take in a large breath and you attempt to exhale forcibly. So you breathe in and you try to breathe out. Okay, but obviously your mouth is closed and your glottis closes, right? Your epiglottis. So something important about the Valsalva maneuver, during the fourth phase, it's used as a clinical marker to test your baroreceptor reflex competence. So if you don't know what's the baroreceptor reflex, it's, for example, when you have a sudden increase in pressure that stimulates your baroreceptor to tell your heart to slow down. Okay. Or vice versa, but let's just move on and we'll talk about this more. Okay, so the Valsalva maneuver can be divided into 4 phases: first, second, third, and fourth. Your first and fourth phases are characterized by a significant decrease in heart rate. Okay, so that's the most significant part of your first and fourth phases, but I'll get into them one by one. Okay, first of all, I want you to think of your aorta as a tube, okay? Which it is, obviously, but just so you can kind of visualize it in front of you. And you can look at the thoracic cavity here in front of you, so you can kind of centerize yourself, you know? First of all, arterial blood pressure increases, okay? As you start the Valsalva maneuver, you hold your breath, you push it out, you close your epiglottis, your intrathoracic pressure will increase. When you do that, you will compress on the aorta, right? When you compress on the aorta, you said, like I said, it's a tube filled with water, okay? Water, blood, whatever you want. You compress on it, the water will be pushed up, right? So that increases the pressure, right? So when you increase your blood pressure, like I just told you, your baroreceptor reflex will realize that there's a lot of blood flowing. So it thinks that there's a lot coming out, so it will decrease your heart rate. That's why here in the first phase, there's an increase in blood pressure, but there's a decrease in heart rate. So whenever you have an increase in blood pressure, it will be accompanied by a decrease in heart rate, okay? And whenever you have a decrease in blood pressure, it will be accompanied by a slight increase in heart rate, okay? Just keep that in mind, because this is the whole basis of the Valsalva maneuver. So like we said in the first phase, increase intrathoracic pressure, and you will increase the blood pressure, which will decrease your heart rate due to the baroreceptor reflex activation, right? Okay, is that clear? I will assume that that's clear. Okay.
Yes.
Okay, thank you. Okay, the second phase, the arterial pulse pressure and the mean arterial pressure begin to decline. Okay, so we said that in the first phase, we increase the intrathoracic pressure, right? Because when we pushed up, we increase the intrathoracic pressure. When you increase the intrathoracic pressure, your venous blood will not return properly. So the thing is with venous blood, as you guys probably already know, since you did your cardio midterm, venous, there's nothing that pumps the blood in your veins. There's no pump. It's not like the arterial blood where the heart keeps pushing it out, and bringing it back, right? Your venous blood depends on pressure gradient and your skeletal muscles, right? So if I do this, and there's the blood in my veins is just there, but then I contract my muscles, the blood will be pushed from my veins to the next part because they're valvular, right? So initially in phase 2, the arterial pulse pressure and mean arterial pressure will begin to decline because of the high intrathoracic pressure. So if you have a high intrathoracic pressure or a high pressure in the area near the heart, we said that veins need a pressure gradient, right? So if the pressure up is higher than down, the blood won't move to an area of higher pressure from an area of lower pressure, right? So your mean arterial pressure will begin to decline, right? Because there's not much blood coming back, so there's less venous return. If there is less venous return, there will be less stroke volume and pulse pressure. Does that make sense? So because of the high pressure, right? Because of the high pressure, the venous blood won't return, because blood will move from lower to higher pressure, not from higher to lower pressure, not from low to high. So from down to an area of higher pressure, it won't come, right? So you'll have a decrease in venous return, stroke volume, which will cause a decrease in stroke volume and pulse pressure. And then the second part of the second phase, over the next 5 to 10 seconds, a reflex increase in the sympathetic outflow causes the heart rate and peripheral vasoconstriction, causes an increase in heart rate and peripheral vasoconstriction, which stops the mean arterial pressure from declining. Okay? So initially we said during the second phase, the mean arterial pressure is declining because the venous blood isn't coming back. So if there's less venous return, there is less stroke volume and pulse pressure. Then when that happens, like I said before, if there is less blood pressure, there will be higher heart rate. Like I said here, if there's less blood pressure, there will be a higher heart rate. If there is a higher blood pressure, there will be a lower heart rate. So when the blood pressure decreased over the next 5 to 10 seconds, your sympathetic outflow causes an increase in your heart rate and peripheral vasoconstriction. If you guys already took that, the blood vessels only have sympathetic innervation, right? No parasympathetic. So to vasodilate, you would remove sympathetic, and to vasoconstrict, you would stimulate sympathetic. Is there any question about the first and second phase of Valsalva? If you have a question, ask now. This is very important. Very, very important. If you don't understand, I'll explain again. Chat. All good. Okay. Okay. Okay, so phase 3. So we finished with phase 1 and phase 2. Now we're at phase 3. When you start to terminate or end your Valsalva maneuver, your intrathoracic pressure will return to normal, right? There is someone in the chat. Don't stop. Okay. I won't stop unless someone asks. Okay. So when you stop the Valsalva maneuver, your intrathoracic pressure will return to normal. Makes sense, right? So you do this, you let go, your pressure starts to become normal. And the thoracic aorta will decompress. Remember how when we increase the pressure, the aorta kind of got pushed in, right? And the blood in the aorta was pushed out, increasing the blood pressure. Now it will decompress, right? So when it decompresses, the arterial blood pressure falls initially. Transiently means initially, sorry, transiently. So the arterial blood pressure will fall, giving a reflex rise in heart rate, right? Whenever your blood pressure falls, you will have an increase in heart rate. Okay, so I guess this makes sense, right? So when you decrease your intrathoracic pressure, blood pressure will go down, your aorta will decompress because so the blood pressure will go down, and your baroreceptor will relax, right? So your baroreceptor will increase your heart rate. Okay, if blood pressure goes down, heart rate goes up. Okay. Okay, now during phase 4, which is very important, probably the most important phase. This phase is the one we clinically use to test the competence of your baroreceptor. During phase 4, your pulse pressure and your mean arterial pressure are increasing steeply. There's a sudden increase in your MAP and your and your pulse pressure. When you increase your MAP and your pulse pressure, it's because of the blood surging right into the thorax. So remember how we said that blood doesn't move from an area of lower to higher pressure, it moves from higher to lower, right? So when we decrease the intrathoracic pressure, the venous blood will return, right? Because now the pressure is less than your peripheries or your lower limb or your arms or whatever it may be, right? So all the venous blood will return. And this sudden return will cause a high blood pressure, which will cause your baroreceptor reflex leading to bradycardia here in your fourth phase. See, you see how there's a lot of blood returning in during the fourth phase. Your baroreceptor will realize, okay, there's a lot coming back. We need to calm down. There's a lot of blood. We need to slow the pumping. So you will get transient reflex bradycardia. Okay. Like I said before, please remember, okay, your fourth phase is used clinically to test for the competence of your baroreceptor reflex. Okay. Is there any question about the 4 phases of the Valsalva maneuver? Okay. If there are any questions, feel free to ask at any time. Okay. The Valsalva maneuver. So like we said before, there can be chronic use of the Valsalva maneuver, right? So like people who have chronic constipations, some GI problems, they can't. Phase 2, can you repeat it? Okay, I'll get back to it. Let me just finish this point, okay? So chronic constipation can lead to hemorrhoids. So hemorrhoids is basically similar to varicocele, only in your colon area, right? So hemorrhoids is basically when there's a lot of blood for a long period of time, so your veins stretch, right? So it's more difficult for the veins to come back to normal. This is because of frequent Valsalva maneuver, because of chronic constipation. Makes sense, right? And this can also occur in people who work out but use the wrong form. Like I told you in the beginning, whenever people who lift weights, they go, right? They breathe so that they don't accidentally get chronic use of the Valsalva maneuver, and which can lead to hemorrhoids. Also, please remember this. This looks very, very important. I don't understand why he wouldn't ask you this in your final. In heart failure patients, Valsalva maneuver can be fatal. Okay, so he could ask you that, for example, a patient came to you and whatever, the resident realized there's heart failure, right? So what would you not do, or what could be fatal for this patient? A Valsalva maneuver. Okay. So in a person with a compromised heart, elevated cardiac work and oxygen demand, especially during the first and the fourth phase. The first and the fourth phase, which are areas of low heart rate but high blood pressure, right? Can lead to ischemia and a heart attack. So heart patients must take measures to prevent constipation so that they don't use Valsalva maneuver. Okay, so
someone's asking you to repeat phase 2.
Yeah, I'll get back to it now. So phase 2. Okay. So in phase 1, we said that you increase your thoracic pressure, intrathoracic pressure. So you compress on the aorta, right? When you compress on the aorta, you increase your blood pressure. Your baroreceptor will decrease your heart rate. Okay? During phase 2, your arterial pulse pressure and your mean arterial pressure begin to decline. Why is that? Okay. So, okay, let me draw. That's a highlighter. Okay. So this is an area of your veins. Okay. Let's say this is your lower limb. Okay. Lower limb. This is your upper limb or thoracic area, okay? If the pressure here is low, okay, and the pressure here is high, the blood won't move up, right? Because blood moves from an area of higher pressure to lower pressure, right? It makes sense. You press it, you increase pressure in this area, it will move to the area where there's low pressure, right? So if the intrathoracic pressure is high, the blood in your veins won't return. This is what happens here. Your arterial pulse and mean arterial pressure begin to decline because of this. Your high intrathoracic pressure will not allow your venous pressure to return, your venous blood to return. Okay, so when this happens, over the next 5 to 10 seconds, you will have increase in sympathetic flow. Okay? When you have increase in sympathetic flow, what will you do? You will have an inotropic and chronotropic effect on your heart, right? So you'll increase your heart rate, you'll increase your contractility. Another thing sympathetic does is that it constricts your blood vessels, veno and vasodilation. So when you constrict your veins, the blood will be pushed up, right? So the heart is trying to compensate for the decrease in mean arterial pressure and pulse pressure. Okay? Does that make sense? There's no name, 230586. Does that make sense? I will assume it does, since you're not saying anything. Okay. Let me go back to the pointer. Okay, so that's it for the Valsalva maneuver. Does anyone have any questions?
You are good to go.
Okay. If there are no questions, well, I'll ask a question. I would like a volunteer. Can someone please unmute their mic and help me solve this question? Come on, anyone. Hello? Read it yourself. Okay. So when the Valsalva maneuver is used as a cardiac function test, the patient is asked to exhale forcibly against a closed glottis. The testing physician monitors the normal physiological body response to continued strain for about 10 to 25 seconds. After the beginning of the test, a rise in which of the following is monitored? So does anyone know the answer? Okay, D. Does anyone have any other answer? A, D, A. Okay. Okay, so the correct answer is D, heart rate, right? So when the Valsalva maneuver is used as a cardiac function test. So like I mentioned before, in the fourth phase, right? We use it as a cardiac function test, right? It's just the competence of your baroreceptor reflex. The patient has to exhale forcibly, closed glottis, testing physician monitors the normal physiological body response, continued strain of about 10 to 25 seconds, right? So the first thing that, or the thing we monitor for always is the heart rate, right? Because we want to see if the baroreceptor worked or not. So yeah, that's it for this question. Yeah, D is the correct answer. Okay, next is shock. That's a very shocking font size. The Aisha just started. Do you guys want to take a break to pray Aisha, or shall I continue with shock and then we can pray Aisha after shock? Guys, please reply, continue. Okay. After shock, okay. Okay, so shock, what is it? So first of all, this is a slide from POD. So yeah, you will be taking shock in POD, inshallah, from Dr. Rayhan's lecture. Shock can be classified into many different categories, but to put shock simply, it's blood not getting to your body organs properly, okay? That's to make it very, very simple. So shock can be cardiogenic, hypovolemic, septic, anaphylactic, or neurogenic. So shock or number one, this I'm reading the slide right now. Number one is an inability of the heart to pump adequately, which is cardiogenic, right? Two is the decreased effective blood volume. So this is hypovolemic. For example, people who have severe burns, they get severe burns, or for example, a mistake in a surgery that can lead to blood going everywhere and bleeding out, or someone who has a very bad wound that can lead to hypovolemic shock. Basically, decreased amount of blood. Okay. And then three is widespread vasodilation, which is septic shock. Septic shock. I wanted to ask if anyone knows what septic shock is, but I don't think anyone's going to reply. Septic shock is basically due to bacterial toxin infection. Yeah. So the bacterial toxins cause your body to release a lot of vasodilators, histamines, prostaglandins, etc. Nitric oxide. You'll vasodilate your blood vessels, and the blood will not perfuse properly to your organs. Okay. Anaphylactic shock is basically allergic reaction, and it's basically the same concept or the same mechanism as septic shock. And neurogenic is related to the brain, and also the same concept as septic shock, where it's kind of vascular permeability complication. Okay, so shock, normal circulatory shock depends on three things. Okay, inadequate blood volume or hemorrhage, inadequate cardiac function, which decreases cardiac output, or an inappropriate vascular tone, like blood vessels, like we said in septic, anaphylactic, and neurogenic, right? So we're going to be talking about these different types of shock: hypovolemic, cardiogenic, and those types of shock. And these are the three things that you kind of relies on whether a patient gets shock or not. Okay. So if there's inadequate blood volume, or inadequate cardiac function, or inappropriate tone of vascularity, right? So first of all, hypovolemic shock. So as you can see here from the picture, it's like your blood leaking, right? So hypovolemic shock, also known as hemorrhage, right? Shock, hypovolemic shock caused by hemorrhage, dehydration, severe diarrhea, vomiting, or like I said before, severe burns. Okay. That's it for hypovolemic shock. Quite simple, right? And then we have compensated shock. So it's shock that you compensated for. The body could react enough, right? So with blood losses of 10 to 20% total volume, a reflex compensation can usually restore your mean arterial pressure. It can restore it close to normal, almost normal. You can function, but then you would go to the hospital, get an IV, right? Or you're already at the hospital and they just give you an IV depending on what the situation is, right? So it will be close to normal in terms of organ perfusion, oxygenation, and mean arterial pressure. The normalization of the blood pressure is due to your increased heart rate, which can be sympathetic, right, by receptor, increased cardiac contractility, vascular resistance, decreased venous compliance. And all of those are due to your sympathetic system, right? Your autonomic nervous system. Increased heart rate, which is inotropic effect, chronotropic effect, also, which is contractility. I believe so. I hope I didn't mix those up. And increased vascular resistance, which means you can say vasoconstriction, and decreased venous compliance, which also means vasoconstriction. So when a vein is non-compliant, it's not stretchy, it's stiff, right? You can think of it that way. And fluids must be administered or ingested, like I said before. So this is a box that the doctor had in his slides that we should probably read. Even though blood pressure may be normal, cardiac output may remain depressed due to reduced stroke volume. So even though the blood pressure is normal, your cardiac output can stay low because of the reduced stroke volume. That's it. So that's compensated shock. And then obviously if there's compensated, there's decompensated shock, right? As shock progresses, the compensatory mechanisms, which being increasing your heart rate, vasoconstriction, venoconstriction, contractility, so on and so forth, they'll reach a maximum. Your heart can't increase its contractility and rate forever. It will reach a point where it can't increase anymore, as well as your vasoconstriction. It can't constrict further than whatever is its maximum, otherwise it will close or kind of like shut down, which would be useless and cause the opposite of what we need, right? And that leads to decompensation when the body reaches a point of maximum, okay, and then the shock continues, then that will lead to decompensation. You can't compensate for this anymore. So your metabolic demands are not met. You can get ischemia, which will lead to some mediators being released, and you can get hypotension and dyspnea, which is shortness of breath. You're studying pulmonary right now, so you should know this probably. You can get acidosis, and you will have cool and pale white skin. So blood is what makes your skin warm, right? So if there's less blood perfusion, you'll feel cold, right? Or your skin will be cold. And you can have mental confusion as there's less blood or less oxygen going to your brain, right? And now we have irreversible shock. So when you get to the point of no return, it's not decompensated, it's not compensated anymore, there's nothing you can do anymore. Irreversible shock. If decompensated, okay, shock continues without treatment, or the blood loss is greater than 20%, it can result in irreversible shock. So when it's irreversible, it's a point of no return, right? If it's a point of no return, that means it cannot be corrected. And it can cause deterioration of your cardiovascular, your circulatory, endocrine, and central nervous system, right? Ultimately, this will lead in infarctions, organ damage, hypoxia, and ischemia, right? Because you're getting less blood, less oxygen to your organs and your systems. Is there any question until now?
All good.
Okay, thank you. All clear, all clear. Okay, great. Okay, cardiogenic shock or heart failure, right? So heart failure is the inability of the ventricles to pump blood at sufficient volume. That makes sense, right? So it's usually to impaired cardiac function, so an infarction or heart failure, right? Which is shock, right? So it can be characterized by left heart failure or right heart failure, and it can be either systolic or diastolic, right? So a left heart failure can be systolic or diastolic, and a right heart failure can be systolic or diastolic. That's quite simple, cardiogenic shock is quite simple. This is also from Dr. Rayhan's POD lecture for shock. It's a table that kind of summarizes your cardiogenic, hypovolemic, and septic shock. So I suggest you guys go through this if you want. It's very helpful. This is a table I found on the internet. There are some things you don't need, like your oxygen saturation and wedge pressure. And central venous pressure, you might want to look at it, but I don't know, maybe. And I guess it's the same for everything. Cardiac output, heart rate, and systemic vascular resistance are probably the most important. So this is a good table to look at. So this is another checkpoint. Are there any questions? Does anyone have any question?
No, thank you, doctor.
Okay, I'm not a doctor yet, but thank you. I appreciate that. Okay. So I have questions. Would anyone like to volunteer to read? Okay, I'll read. So hypovolemic shock, cardiogenic and distributive shock due to sepsis, right? Have which of the following abnormally low features in common? So all of these, hypovolemic, cardiogenic, distributive shock. We didn't really talk about distributive shock, but cardiogenic and septic hypovolemic we talked about, right? So what do they have in common? Can someone answer? Does anyone know the answer? Okay, someone said D. Someone said E. E is unfortunately not correct. D is correct, yeah. D is the right answer, which is oxygen delivery to the tissues, right? So in all of these, you will have less oxygen going to your organs in your body, right? Yeah, D is the right answer, yeah. Yeah, okay, almost everyone got that right. Okay, good. That's good. Nice. Okay, so I have another question here. Yeah, that's the answer. And there's the explanation, and it's from Team Test Prep. I suggest you solve this book. It's very good. So 2 patients in the ER are diagnosed with shock. One is suffering from anaphylaxis, from a bee sting, and the other is suffering from obstructive shock from cardiac tamponade. So you can say it's cardiogenic, right? What is expected for each patient's central venous pressure when compared to a healthy normal patient? Does anyone know the answer? Okay, so let's take this one bit by bit. Okay, so anaphylactic shock, right? So anaphylaxis, we said, can be from bacterial toxins, right? So that would be because of vasodilation, right? Someone said D. Okay, good. I'll just explain for everyone else, and then I'll tell you if it's right. So anaphylactic is due to vasodilation. So will that cause an increase or a decrease in mean arterial pressure? If you have vasodilation, will that cause an increase or decrease in mean arterial pressure? While in, yeah, it will cause a decrease, yes. So which ones cause a decrease? D, E, and F, right? So until now, only these are right. And then when you have obstructive shock due to cardiac tamponade, right? So your heart is being pressed on, right? So it's going to try to pump faster and harder, right? So is that going to increase or decrease or not change your central venous pressure? Does anyone have any idea? It's okay if you increase. Yeah, it will increase. Yes. Yes. So by default, D is the right answer, right? Yeah. So if you have the, yeah, so D is the right answer. Okay, good. So that's it for shock. Next is heart failure. It's right versus left heart failure, and systolic versus diastolic. Do you guys want to take a break so we can pray and then we'll come back to this?
If you need less than half an hour, I think we can move on.
I think I might take half an hour. Do you guys want a break? Can you please explain the second question once more? Okay. Okay, so we have two patients in the ER. They're diagnosed with shock. To put it on the table there, they have shock. One is suffering from anaphylactic shock, right? We said anaphylactic shock is due to bacterial toxins, right? And it's vasodilation because you release a lot of your histamines, your prostaglandins, your nitric oxide, which vasodilates your blood vessels, right? So the first one is anaphylactic, which causes vasodilation, right? If you have vasodilation, you will have a decrease in your central venous pressure, right? So total, you'll have a decrease in your pressure. So it's one of these, right? For anaphylactic shock. While for obstructive shock from cardiac tamponade, it's because here you can read the explanation here if you want. It's because of the compression of the heart by fluid accumulation, which I said before. You'll kind of compress on the heart, right? And the compression prevents proper filling, which causes a backup in venous system, right? So that will cause an increase in your venous pressure. I didn't really explain this very well, but it's right here, right? So it will cause the backup of blood into the venous system, which will cause an increase in your central venous pressure. Okay, good. You're welcome. So do you guys want a break or shall I continue? I want the chat to answer, yani, please. $10 minutes? Okay. Okay. Okay, we'll take a 10-minute break. And then we'll come back. Okay. So we're gonna start again. Okay. So next we have heart failure. Please stick with me, okay? Stay with me. This is very, very, very important, okay? So, and it might be a bit difficult, but inshallah I'll make it easy. So just stay with me, okay? Heart failure. Simply, the heart is unable to pump blood around the body properly. Simply, okay? So we have left versus right-sided heart failure, okay? Left-sided heart failure is due to failure of the left ventricle to pump blood properly. So this can be systolic or diastolic dysfunction. This will lead to a decreased cardiac output, an increased pulmonary volume, and increased pulmonary capillary pressure. So this tells you that the blood will back up and go to your lungs, right? Which will cause pulmonary edema, right? You will have less LAP enlargement, right? Left arterial pressure enlargement. And you will have a right heart failure. You can get right heart failure from left heart failure. The most common cause of right heart failure is left heart failure. The most common cause of left heart failure is right heart failure. I believe so. Just so I didn't tell you anything wrong. I have it here somewhere. Okay. Yeah, okay. And then we have right-sided heart failure. So in right-sided heart failure, your central venous pressure is increased, okay? That will lead to an increase in systemic capillary, hydrostatic, and pressure and peripheral edema, okay? So your systemic capillary hydrostatic pressure will increase and you'll have peripheral edema. So in left-sided heart failure, pulmonary edema. In right-sided heart failure, peripheral edema, right? It only makes sense, right? So what brings the blood to the left side of the heart? The blood comes from the lungs, right? So if the blood backs up, it goes to your lungs. Right side of the heart, the blood comes from the body to the heart, right? So if to the right side of the heart. So if blood backs up, it will go to your peripheries, your lower limb, your legs, your arms, whatever it may be, right? So obviously can be right or due to failure of the right ventricle, obviously, and can be systolic or diastolic again. Okay, and this leads to a decrease in pulmonary volume, a decrease in left heart volumes, a decrease in cardiac output, obviously, an increase in systemic not pulmonary capillary pulse pressure, and you will have peripheral edema, like I said before, RIP enlargement, elevated jugular venous pressure. Okay, so just keep in mind, right-sided heart failure, peripheral edema, left-sided pulmonary edema. Another thing, left-sided heart failure causes right heart failure because the blood back in the lungs, resulting in increased resistance for the right heart, leading to its failure. Okay. Okay. Is there any question here?
Can you say that one more time?
The last part.
Yes.
Okay. So there's this thing called cor pulmonale, which I will talk about. It's here somewhere. It's in the concept maps. I just showed you all the answers, but here we'll talk about cor pulmonale. Where is it? I think it's here. Yeah. Cor pulmonale. So basically, when the left heart, I actually wrote it down probably. So cor pulmonale. Okay, it's long-term high blood pressure in arteries of the lung and right ventricle of the heart. I don't know if that makes sense. Okay, so basically the left heart failure causes right heart failure, right? Because the blood backs into the lung, resulting in increased resistance for the right heart. So the blood that's in the lung, right?
I think that makes sense. Yeah.
Okay, I'll just make it a bit clear. So the right side of the heart pumps blood to the lung, right? So if there's a lot of blood there, it will be difficult for the blood from the right side of the heart to go to the lung, because like we said before, it's from an area of higher pressure to lower pressure, right? But if there's a lot of pressure in your lung, okay, I'll recap the slide. If there is a lot of pressure in your lung, your right side will have a difficulty in pushing blood to the lung, right? So left-sided heart failure, which will cause pulmonary edema, can cause right heart failure. So when you have left heart failure, you get pulmonary edema. So the blood backs up into the lungs, right? So if the blood backs up into the lungs, there will be a high pulmonary capillary pressure, and blood needs needs to move from high to low pressure. But if the pressure in the lung is increased because of the left-sided heart failure and the pulmonary edema, right, the right heart will have a difficulty in pushing the blood into the lung. So it can cause right heart failure. Okay, I'll recap the slide quickly. Okay, so left and right-sided heart failure, right? Left ventricular failure, right ventricular failure. Both can be systolic or diastolic. So both can be due to contraction or relaxation. Both have a decrease in cardiac output, and both lead to edema. Okay, left-sided, so the blood in the left side of the heart goes to the lung. So if the blood backs up, it will back up into the lung. So you'll have pulmonary edema. The right side of the heart is supplied by the body. So the venous system goes to the right side of the heart. So from your legs, from your arms, all that blood goes to your right heart. If the blood backs up, it will back up into your body, right? So you will have peripheral. Peripheral meaning your peripheries, your fingertips, your feet, your hands, your legs. But it's probably going to cause lower limb edema. Is more common, if I'm not mistaken. So peripheral meaning your peripheries, okay? In left-sided heart failure, you will have an increase in pulmonary volume. Makes sense, pulmonary edema, right? A lot of blood, a lot of volume. You'll have an increase in pulmonary capillary pressure. Also makes sense because of the pulmonary edema, right? In the right side, you will have decreased left heart volumes. Okay, so if your right heart isn't pushing blood to the lungs, right? The lungs is where the blood comes from to the left heart, right? So if the place where the left heart gets its blood doesn't get blood, then you will have decreased left heart volumes. I hope that makes sense. So basically the reservoir of the blood for the left heart isn't being supplied by blood. So you'll have a decrease in left heart volume. Obviously you'll have a decrease in cardiac output again. You will have systemic capillary pressure increase, not pulmonary, systemic for right side, and peripheral edema, like I said before. Any questions again about this? Do you want me to explain the left to right heart failure thing again? Does it make sense?
All clear, doctor.
Okay. No, thank you. Okay, fine. We'll move on. Okay, so now systolic versus diastolic dysfunctions, okay? So systolic meaning, obviously, you guys know contractility and relaxation, right? So systolic is due to reduced ability to contract or eject the blood. That's literally the function of contraction. Excuse me. So it can also be left or right heart. And as well as how left and right can be systolic or diastolic. Systolic and diastolic can be right or left. Only makes sense, right? So the causes, stuff that can cause systolic dysfunction is a myocardial infarction, which is reduced contractility, a chronic aortic valve stenosis, which increases after load. So basically, if you have aortic valve stenosis, your ventricle will contract, blood will not leave as well as it should be, so it will stay in your ventricle. So you will have systolic dysfunction because of chronic aortic valve stenosis or aortic stenosis in general, right? Uncontrolled systemic hypertension. You have hypertension, that is a systolic dysfunction. Okay, diastolic dysfunctions. The term diastolic refers to the change in ventricular diastolic properties that have an adverse effect on the stroke volume. Okay, so it's due to reduced ability to relax for the ventricles to fill. So if the ventricles can't fill properly, you can't supply properly, right? So you will have an adverse effect on your stroke volume. Also could be left or right, obviously. Its causes can be reduced ventricular compliance. So your ventricles can be more stiff, less compliant, and which can be caused by concentric hypertrophy. Okay. You can have reduced chamber volume. So your end diastolic and your stroke volume will be less. And that will cause diastolic dysfunction. Reduced preload from mitral valve stenosis. So your mitral valve is your atrioventricular valve on your left side, right? So if that is stenosed or stiff also, the blood from the lungs or from the venous system, from the pulmonary veins, will have difficulty in going to your left ventricle. So you will have a diastolic dysfunction, which means filling, right? So you will have an issue in filling because not enough blood is coming back to your ventricle properly. Is this clear? Okay, clear? Okay. Okay, good. Okay, pressure volume loops. Okay. So before we start, this is your diastole and this is your systole, okay? So systole starts here and ends here, your diastole starts here and ends here, okay? This is filling, this is ejection, okay? So your PV loop changes in left ventricular heart failure, in systolic dysfunction. We're only going to be talking about.
Can you please repeat the points?
About the table?
Yeah, please.
Okay. So this is diastole. This here is diastole. From here to here is diastole. This is the normal. Forget this for now. We'll talk about it in a second. This is systole. From here to here is systole. This is filling, right? And this is the beginning of systole. So this is your preload, right? This is your ejection, right? Or your stroke. And this will be your afterload. Okay, so your pressure volume loop changes in left ventricular heart failure or your systolic dysfunction. Okay, so left ventricular heart failure and systolic dysfunction. You will have decreased inotropy. You will have a decreased slope for end systolic pressure volume relationship. So this is the normal. The slope will go down. Okay. We will talk about systolic, and systolic will not be your end systolic, will not diastolic. I mean, it will not affect your end systolic pressure volume relationship. It will affect your diastolic. Okay, we'll talk about it. And diastolic will go up, systolic will go down. Okay. So your slope for end systolic pressure volume relationship will go down. Your stroke volume, okay, will be less. Your end systolic volume will be more. So this is your end systolic volume, right? It's about here, 50 almost, I would say, right? Your end systolic volume is here, right? This is your systole ended end systolic volume, 50. In left ventricular heart failure with systolic dysfunction, obviously the issues in systole, right? You will have way more still in your ventricles, way more blood still in your ventricles. So your end systolic volume will be more. So it will move from here to here. So this volume will be more from here to here, from 50 to about, I'd say 105, maybe something like that. And your end diastolic volume would be more. So we said this is diastole. It starts here and ends here, right? So this is your end diastolic volume, also known as your preload, right? So if your end systolic volume is more, you will have blood left over from the previous cardiac cycle. The next cardiac cycle will add a normal amount of blood that it should usually add. So if you already have, and you add more into it, you will have an increase in end diastolic volume, right? So after rest, you already had from before, and then you get an extra normal amount, you will have an increase in your end diastolic volume, okay? And obviously the end diastolic pressure volume relationship is normal in systolic dysfunction. Your ejection fraction will decrease. I believe this is your ejection fraction. Here it's about 50 to 150, I would say about 70, your ejection fraction, and here it will be about 40 maybe. There's not the exact number. Systolic dysfunction will result in heart failure, will result in heart failure with reduced ejection fraction, okay, which will cause a decrease in your stroke work. So something that is in common between systolic and diastolic dysfunction is that they both have a decreased stroke work, okay? Keep in mind in systolic, you will have heart failure with reduced ejection fraction, okay? Like I said before. In diastolic, since we're on the topic of ejection fraction, you have ejection fraction will not be affected, so it will, or not as much. It's called heart failure with preservation of ejection fraction. Okay. Excuse me. So let's talk about this diastolic dysfunction from the beginning, and then we'll relate it to systolic again. So systemic hypertension, right? So you can have a decrease in ventricular compliance, which means your ventricles are stiff, associated with concentric ventricular hypertrophy, which I said before. Where is it? Yeah, concentric hypertrophy, right? Diastolic dysfunction. Diastolic dysfunction, concentric ventricular hypertrophy. You will have an increase in your end diastolic pressure volume relationship. You will have an increase. Okay, systolic, systolic, diastolic, diastolic. Systolic will go down. Your systolic pressure volume relationship will go down. Your diastolic pressure volume relationship will go up. Okay? So please keep this in mind. It's very important. In your systolic, your systolic pressure volume relationship will go down. Diastolic pressure volume relationship will go up. Okay? You will have a decrease in the filling, so therefore you will have a decrease in your preload, right? Remember we said this is the diastole, right? So this is the preload, which is the end diastolic volume, right? So this is the preload here. This is the new preload with the diastolic dysfunction. It will decrease. If the slope increases, will the contractility increase? In systolic here, do you mean this slope, or do you mean, oh, you mean this slope, right? I don't think it will try, right? Because you have hypertension, right? You will have a baroreceptor reflex, which will in both. Well, okay. Well, here you won't have an increase in the slope. In systolic function, dysfunction, you'll have a decrease in the slope. The problem is in contractility. Okay, you want the in systolic? Okay, this is for systolic. By the way, this is diastolic. Okay, please don't get confused. This is EDPVR. This is ESPVR. Okay, so when you have a decrease in your slope for your end systolic pressure volume relationship, that just means the pressure and the volume aren't really together, because your volume increased, right? But the pressure didn't change, right? So you can see here, right? The pressure is almost about the same, right? But the volume increased. So if the volume increased and the pressure didn't change, that doesn't make sense, right? Because the pressure we have, subhanAllah, Allah gave us this specific pressure that we need for the specific volume of blood that we should pump, right? But if we increase the blood, we will need to increase the pressure, right? But if we increase the blood and we don't increase the pressure, the curve will go down, right? Because the blood will stay, right? So we'll have an increased end diastolic volume or your preload, and you'll have an increased end systolic volume or your afterload. So the curve will go down, and your systolic dysfunction, your end systolic pressure volume relationship dysfunction. This is systolic, not diastolic. Please don't mix up. They're different. Okay. Your end diastolic pressure volume relationship. Okay. Here, I believe the pressure changed, but the volume didn't. Okay. So the volume is almost, well, the volume did, but it's because of the pressure change. And you have also systemic hypertension, ventricular compliance, and decreased ventricular compliance, right? So just think of it the same way. So if here it will decrease, here it will increase, right? So here, if you have an increase in volume, you will have a decrease in your systolic slope. If you have a decrease in the volume, you will have an increase in the diastolic slope. Okay. Okay. So there's little, like I said before, there's little change in your. Oh, so I didn't talk about the endostolic volume. Oh, I did. Your stroke volume will decrease. Your endostolic volume will decrease, like we said before, which is your preload, right? You're welcome. You're welcome. Okay, your stroke volume will also decrease, right? This is your stroke, right? So it's less volume is being pushed out. Ejection fraction here is preserved, okay? So HFPEF. So a heart failure with preserved ejection fraction. And obviously you will have decreased stroke work in both. Is there something that's unclear that you want me to maybe go back on? Was the pointer not clear?
No, the pointer is clear.
Okay. Does anyone have any other question? This is very important. This is like the most important part of the lecture. Okay. Okay, now moving on to the cardiac index. I have questions about heart failure, by the way. I'll ask you guys, okay? Moving on to the cardiac index. All clear? Okay, good. Okay, good. So the cardiac index relates to the cardiac performance to the size of the individual. So the normal cardiac index is about 2.4 to 4.2 liters per minute per square meter, right? If the cardiac index falls below 1.8 liters per minute, a patient may get or develop cardiogenic shock. It's a simple formula. Cardiac index is cardiac output divided by your body surface area, right? So to emphasize on cardiac index, it relates to the cardiac output to body surface area, which relates the heart performance to the size of the individual. The normal range, which we said before, is 2.6 to 4.2 liter per minute per square meter. And if it falls below 1.8, patient may present with cardiogenic shock. Okay. Is there any question about cardiac index? It's very straightforward, I think. If there's any question, please ask. Okay, I guess all clear. Okay, checkpoint. Any questions about heart failure, systolic, diastolic, right-sided, left-sided, PV loops? This is very important. So if you have any question, please be the one to ask. Maybe someone else has a question, they just try to ask. Don't be shy, it's fine. Okay. If you guys come up with a question, you can ask me. And inshallah, I'll try my best to answer. Okay. So I have questions for you guys. So would anyone like to read? I'll try this one more time.
I can read.
Okay, go ahead.
Okay, so the question says a 64-year-old man with a history of mitral valve stenosis presents to his general physician with complaints of difficulty breathing. The patient is diagnosed with left heart failure due to chronic mitral valve stenosis. Which of the following cardiac findings will most likely be present?
Okay, so answer in the chat, everyone. Do you guys know the answer? Can you guess? Guess. I think I explained this and I emphasized this a lot. Left-sided heart failure. E. Yes. Yes. Thank you very much. Thank you very much. The answer is E, indeed. The answer is E. Okay, good. That's good. Alhamdulillah. Okay. Another question. Would someone else like to read? Or shall I just read? I'll read. So a patient with right heart failure presents with shortness of breath. Tests reveal right ventricular hypertrophy. So right heart failure, could be right heart failure, right? A systolic murmur and pitting leg edema. Okay, so leg edema, now we know it's right heart failure, right? There is no indication of left ventricular failure. Nothing wrong with your left ventricle. So the right heart failure is not because of left ventricular heart failure, like we mentioned before. Left heart failure can cause right heart failure, right? So it's not because of this. So which of the following hemodynamic changes is expected in pulmonary capillaries because of right heart failure? Okay, someone says D. Does anyone else have any other answer? This is actually a difficult question. A, okay. This is a difficult question. A. Okay, very good. Yeah, it is. The answer is A, decreased pulmonary capillary hydrostatic fluid pressure. Yes, A. Yes. Thank you. That's very good. So it's basically right heart failure, right? So if the blood in your right heart isn't being pumped very well, it won't go to the lungs, right? So your hydrostatic pressure will decrease in the lung. Okay, good. Okay, I'm glad you guys can answer that. It's okay. That's fine. Got it? Okay, good. Okay, great. Does anyone have a question about these questions? Because they kind of explain heart failure very well. Okay, we'll be moving on. Now, this might look like it's messy, but if you read it, it's kind of organized, right? So this is a concept map for left heart failure, okay? So common causes of left heart failure would be a myocardial. Okay, what would happen to the colloid osmotic pressure? Okay, so you can see here, wait, colloid osmotic pressure, colloid osmotic pressure. Okay, so you remember the Starling forces, right? Okay. Pulmonary capillary colloid osmotic pressure. So here, it was E. The pulmonary plasma colloid osmotic pressure is produced by proteins in the plasma, right? Yeah. This increases if the protein concentration in the plasma is increased, which is not occurring in this patient, right? So I don't think there will be much of a change, but if anything, it would decrease, not increase, because there's less blood going, right? So there's less proteins, but I'm not entirely sure. I will make sure on this and reply to you, and I have my number in the beginning and at the end of the lecture, and if you find out, you can tell me also. Okay, but I'm not entirely sure what happens with the colloid osmotic pressure. Okay. No problem. Okay, so common causes of left heart failure may include a myocardial infarction, uncontrolled hypertension, and valve pathologies can cause left heart failure. Like we said, a aortic stenosis, right? In the left heart failure, left-sided, we said can be caused, where is it? So we said aortic stenosis somewhere. Anyway, if we find it later, we'll talk about it. So boxes in yellow are signs and symptoms. I guess Dr. Simon showed you this exact slide. I literally just copy-pasted most of this lecture from him. And so the yellow are signs and symptoms. So the patient may present with S3 heart sound, a left axis deviation, left atrial enlargement and dilation, a risk of atrial fibrillation, pulmonary edema, obviously because left heart failure, right, can cause pulmonary edema. So let's go through the concept map. He really told me that the concept map is really important. So please concentrate, and I'll go through this, and please go through this on in your own time, okay? He told me that it's very important. I went to him this morning. So severe myocardial infarction in left ventricle. Let's say this is what happened, right? A myocardial infarction. You will have decrease in left ventricular contractility. You will have systolic dysfunction and left heart failure, right? You will have a decrease in left ventricular stroke volume, which will be followed by a decrease in cardiac output. Less blood coming, less blood will be going out, right? You will have an increase in the preload in your left ventricle, which will cause the fluid to back up into your left atrium, which will cause left atrial enlargement or atrial hypertrophy. And the fluid back up into your left atrium can back up into the lungs also, causing an increase in pulmonary capillary pressure, causing an increase in causing pulmonary edema, right? And like we said before, if you have left heart failure, you can get right heart failure. Does everyone understand this concept? How you can get right heart failure from left heart failure? Yes? Okay. So something that's common between the left heart failure and the right heart failure is the S3 sound. But here's something that's amazing. Left heart failure, left axis deviation. Right heart failure, right axis deviation. So this is something that can give you a sign in an MCQ, okay? And is everyone good with this concept map? So shall I move on to right heart failure? Okay. So I will be. Okay, so right heart failure. Sorry. I'll close the chat. Okay. Right heart failure. Common causes of right heart failure, like we said before, left-sided heart failure, right? The most common cause of right heart failure is left heart failure. Okay, so that's why it's very important. If you don't understand it, please let me know. Another thing is the right-sided myocardial infarction and cor pulmonale, which we talked about before, right? Due to the pulmonary hypertension, right? Again, boxes in yellow symptoms, right? Dyspnea, fatigue, jugular venous pressure, peripheral edema, hepatomegaly, jaundice, alanine aminotransferase and aspartate aminotransferase, bilirubin, which are all signs of liver damage. Also, like the S3 heart sound that we talked about before, and right heart failure, so right axis deviation. Was my pointer there just now? Because I have a problem with this pointer. Anyway, so valve pathologies can be auscultated, the S3 heart sound, peripheral edema and jugular pulse can be seen and palpated. Peripheral edema, jugular pulse. Right axis deviation, right heart failure, right axis deviation. So let's go through the whole thing. Acute pulmonary hypertension, okay? Or kind of like cor pulmonale, right? You will have an increase in pulmonary system afterload, okay? Then you will have a systolic dysfunction, so a contractile dysfunction in right heart failure. You will have a decrease in right ventricular cardiac output, a increase in preload in the right ventricle. You will have right ventricular eccentric or dilated hypertrophy, so increase in preload, then eccentric or dilated hypertrophy. Okay, now let's go one by one. A decrease in right ventricular cardiac output can cause dyspnea, right? Because not enough blood is going to your lungs, right? So you will have shortness of breath. Can also cause a decrease in left ventricular cardiac output. Okay, does that make sense? Because from the heart to the lungs to the left ventricle, right? So if it's not going to the lungs, it won't go to the left ventricle. And then you will have fatigue. Nice, okay, thumbs up. An increase in preload in right ventricle. Fluid will back up into the right atrium and will go to your peripheries. You can feel that in your jugular venous, an increase in jugular venous pressure, which can be a sign of acute sign of edema before the swelling happens, maybe. And then you can have okay, then portal system is affected. The portal system, you guys just did GI before cardio. So your liver system, right? Your aspartate aminotransferase, your alanine aminotransferase, bilirubin, and the patient will be jaundiced and he will have hepatomegaly. Okay, and then like we said before, S3 and right axis deviation. And thank you. Does anyone have any questions? This is my number. You can message me on WhatsApp. You can email me. You can call me, but I prefer WhatsApp rather than email. If anyone has any question, feel free to ask. Concept maps, heart failure, Valsalva, shock,